Okay, good afternoon and welcome to the AI Med webinar, Real World Applications of Natural Language Processing in Healthcare. My name is Freddie White. I'm the CEO of AI Med, and we've got a really great session lined up this afternoon. Both Celeste and Callum will be taking the reins and taking us through the webinar. Just before we get started, one of the registration questions was around, would you like to speak to NLP expert? And just to let everybody know, we got a lot of people that were interested in speaking to an NLP expert. So we are going to get to everybody. We'll collate all the data, and then next week we'll begin reaching out to chat with everybody from there. So that's enough of me. So I'll hand it over to Celeste and Callum and just say I hope everybody enjoys the session.
Thanks, Freddie. It's great to be here. As Freddie says, my name's Callum Yakubian. I lead the healthcare product strategy for our NLP product suite and offerings here at IQVIA, and I'll be taking you through the slides before Celeste dives into a demo, and we'll have some time for some Q&A as well. And just want to also thank AI Med and Freddie for having us here. We're delighted to be presenting to so many of you, and so it's great to see so many of you are interested in some follow-up already. And yeah, very much looking forward to the discussion. So I think there's a Q&A box in the Zoom function. So just as we go along, please type your questions in, and we might address them live if we see them. Otherwise, we'll get to them all at the Q&A, or we'll do our best to anyway. So we're going to cover a fair bit of ground. We're going to, first of all, talk about the current landscape of AI and NLP in healthcare, just cover more basics of what actually natural language processing is and its importance to healthcare, before some case studies and demo. So I think, first thing to state is that there is no doubt that the importance of clinical text and text in general has very much kind of come under the microscope in the last sort of 12 to 18 months, more so than ever before. And that's obviously really largely thanks to the release of ChatGPT and how it's basically stimulated everyone's imagination, not just in healthcare, but basically all of us in many ways in our everyday life. And what this has really done is shone a light on the value of text and of natural human language. And that is something that we, certainly within IQVIA and within the NLP team here, have been very aware of for a number of years. But it's great to see this kind of this shift in natural language processing going from something that was pretty niche to something which is really mainstream. And we're at a very exciting time in healthcare, particularly because we have this advent and this kind of AI revolution and the realization of the value of healthcare data sat alongside this picture of ever evolving and growing volume and complexity of data that exists in the healthcare space. I've spoken before about big data being a tired expression, but in healthcare it's still very much relevant and true. There is data growth in healthcare that pretty much outstrips that of any other industry. Hospitals are producing huge volumes of data on a daily basis. Patients are getting older and having more complex conditions. So set in this picture of Gen AI and this healthcare landscape, it's an exciting time for healthcare. I want to kind of start off with this quote, which I read a couple of years ago in the Lancet. This was from a research paper looking at the AI landscape, even a couple of years ago, when, artificial intelligence has certainly been something that's been kind of growing in the healthcare domain for a few years now. And the paper summed up really nicely with this quote, artificial intelligence isn't going to replace clinicians, but clinicians using AI are going to replace those who do not. And I think that is very, very true. I think that we are going to increasingly see the use and application of AI, of which natural language processing is a subset in everyday clinical life. But in very many cases, it's going to be augmenting the practice of clinicians rather than replacing clinicians, research, etc., who are becoming more stressed and strained resources. So before just kind of diving into natural language processing, I wonder, Freddie, if you can launch the first poll. And I have no idea whether or not that's posted or not, Freddie. So if you let me know in the chat. Oh, there we go. Here it comes. Great. So this is just the first question. Are you currently using NLP? And then the answers are yes, you're using it and it's a solution provided by a vendor. Yes, you're using an open source solution. No, but you're interested to learn more. And no, I'm not likely to use it anytime soon. So if you could answer those polls, or that poll question, that'd be great. And Freddie, do I see the results popping up anywhere, or do we just get that at the end?
Yeah, so they are actually coming up in real time. I'm not sure whether you can see them though, Callum.
I'm not, but maybe if you post
Okay.
it, yeah, or you can tell me where to post
I'll do a quick screenshot in a moment, and
Sure.
I'll put it in the chat so you can see it. But yeah, everybody's answering, so thank you to everyone who is who is.
Awesome. Cool. So I'll let those come in. I'm very curious to see what the results are. So I guess the first thing to say about what is natural language processing is that it is something that has been around for a very long time. NLP has been around since potentially the 1950s. Some have it earlier as the 1930s, and it has largely been focused in the area of extracting information from human language, from essentially the way that we as people interact with each other. There have been a number of different methodologies and techniques that have come and gone. Many of them have stayed in that intervening period between then and now. And large language models, and in fact, some of the transformer-based models in sort of the 2018s and onwards, and now obviously with what we're seeing with GPT type models, super large language models, are the latest in a long string of technologies aimed at getting value from and generating value from unstructured text, from text-based interactions. In healthcare, it's very important to notice and to appreciate the differences that exist within natural language. Clinical language itself is something which is very unique to many other spheres of how humans and how people communicate with each other. And so there have been many of these techniques used in parallel in the clinical space in clinical natural language processing. And I think, really still the greatest value of NLP or of language processing within the healthcare domain is the transformation of information within medical records into structured, normalized text for decision support. So when we talk about unstructured data, we're all very familiar with these types of documents: discharge summaries, radiology reports, pathology reports, etc. These can then be processed through the various different techniques that have come and that exist, and all of them actually can work very nicely in synergy and orchestra with each other to derive structured data for a variety of different downstream applications. And we call this, this is essentially information extraction, and extracting rich, accurate information from text, from clinical text. So very simply, I guess, NLP is the ability of the computer to read the complexities of this language, this human language, this clinical language, and extract meaning with accuracy, preserving the meaning and intention of the person who dictated or who transcribed that information. So within healthcare, that means that it has to take account of the various different vagaries that exist within clinical documentation. So healthcare data itself, unstructured data, is very complex compared to many other places in which NLP is applied. We see lots of natural language processing applied in scientific literature, in publications like the Wall Street Journal. Most documentation which has undergone some type of review, either by the person writing it or by peer review. Obviously, clinical letters are created and dictated at the point of care by a clinician. So they are in many ways the kind of first pass narrative of that doctor's experience or reflections on seeing the patient. So they are full of interesting, non-standard English, lots of abbreviations and acronyms. Clinicians often like to document things like the kind of suspected possible differential diagnoses. So we have all this kind of strange context to deal with around kind of possible diagnoses. And then, of course, within medicine, we have multiple different ways that we can say the same thing. That applies in drugs, where we have brand names, generics, but also in clinical conditions where we have sometimes eponymous syndromes, or we may have diseases named by their gene mutation. There's so much variation in clinical language that it's, in fact, often said that gaining a medical degree is almost equivalent to learning a new language, such as the variation and newness of a lot of that language. So all of these kind of different complexities make doing accurate natural language processing in healthcare data actually very challenging, and something which few which many have tried at and many have failed, and few have managed to do successfully and repeatably. If we look kind of more closely at this type of unstructured data that I'm talking about, just to kind of put it into context, and I think very many of us here have clinical backgrounds and are familiar and know this type of data. But we're all kind of used to seeing that type of documents as a synthetic admission note for a patient presenting into a healthcare system. Whenever this kind of admission would happen, of course, clinical coding would take place, and we would expect some structured data to be created from this unstructured data. So the input was the doctor's letter, the output will be the coded data used for administrative purposes. Occasionally, some of this information may be in nicely formatted, structured lab systems, and potentially medications tables, etc. So we might get some of that structured data out without needing any NLP. But when we look kind of more closely at this document, there's a huge amount of richness in here that is left behind by traditional clinical coding. And when we're thinking about stratifying patients by their disease severity, looking at populations and stratifying on risk factors, as I say, the severity of that disease, most of the information that allows us to do that is trapped within these unstructured types of clinical documents. So here we have, of course, the diagnosis, which we had in the structured data, but we also have all of those other signs and symptoms which give us an idea of the severity of this patient's diabetes. So they are symptomatic with it. They're up overnight to pass urine. They have a sedentary lifestyle with a poor diet, high alcohol intake, some social determinants of health here. We're seeing that they have missed appointments to previous clinic appointments, and that they have problems walking, as well as various medications and kind of point of care tests that have been done. All of this information essentially exists only in the unstructured data and is very rarely entered into any structured format, because itself is not diagnostic, it's informative. And coding has never been about capturing patient information, it's always been about capturing patient diagnoses for billing purposes. And therefore we have this huge amount of richness left behind in what's thought to be 80% of the healthcare record, which is unstructured. So natural language processing, particularly pertaining to medical records, provides us with a way to dive into these medical records and normalize, extract this data in a way that can be used for downstream analysis. And we'll touch on some of those use cases as we move on. So I guess I should qualify why we can be here talking about this, why we are qualified to speak about NLP. So maybe I'll just do a little bit of an introduction to who we are as IQVIA, Natural Language Processing team. So IQVIA NLP has been around for a long time. Some of you may be familiar with us as Linguamatics. The company Linguamatics was formed in the UK over 20 years ago now, actually, and acquired by IQVIA about coming on 5 years ago. The technology and the company have been providing value and services to the pharmaceutical industry for probably the last 20 or so years. So our first customers were in the pharma space, where we were mining data like drug labels, patents, scientific literature, and things like conference abstracts, preprints, etc., all informing kind of pharma R&D, so getting kind of intelligence on drug development. But in the last sort of 10 to 12 years, we've taken the same principles of extracting value from text data and translated it and applied it to the clinical domain. And we've been working with leading academic medical centers, payers, different healthcare organizations and government agencies, translating and transforming unstructured clinical EMR data into structured information for, I guess, the last 12 years. And as I say, working with lots of leading organizations that we'll touch on in the case studies. Because we've been doing this for a while and we've been giving value to our customers for that period, we've got loads of publications. So this is very strongly market validated methodologies and techniques and software platforms, over 100 publications. And really importantly, not authored by us. These are all authored by our customers and our clients in their kind of everyday success and use of the technology. We also have a number of awards, which is always very nice for us and our customers to receive. And this bottom right one, the AI Breakthrough Award, we won this this year, announced in July. AI Breakthrough is a kind of relatively new award society or organization that is looking to for the breakthroughs in artificial intelligence across verticals. So this isn't just healthcare specific, but IQVIA won best application of AI in healthcare award, and this was particularly for the use of our NLP to identify patient level social determinants of health from their unstructured notes in the emergency department of an acute hospital. And I'll touch on that case study towards the end, but something that we're really proud to have received. We obviously don't have time to cover everything that you can do with NLP and everything that we've been doing with NLP over the years. And these kind of cover the main principles or the main areas that we apply technology across IQVIA and NLP. As I say, much of today's presentation is going to focus on getting that value from the EMR. So that's around the kind of entity detection, information extraction, document classification, etc. on the left-hand side of this. We are increasingly doing summarization type tasks and question answering solutions for our clients, actually more so in the pharma side, where kind of summarization and generation of results with kind of more generative approaches can be really useful as a sort of a synthesis of insights derived from the information extraction that we do on the left-hand side of this. Typically with more of our medical commercial kind of audiences in pharma, so the group responsible for products once they've gone into the market, the kind of trends and insights that we can get from kind of LLMs is the fastest and best way to get the kind of high level overview that they need of the market, versus a lot of our healthcare applications where we're looking for highly accurate information extraction to support clinical decision support in other areas, as I'll touch on. So our entire kind of technology platform and ecosystem is in the healthcare space is built around extracting information reliably, repeatably, and at scale from the unstructured medical records. And you'll see some of that in some of the tools that we use to do that in the demo from Celeste. The approach that we take combines different methodologies of natural language processing. So we typically tend to combine a mix of clinical ontologies and terminologies with rules-based approaches and machine learning-based approaches to get the most accurate extraction. And we see that kind of applying largely, when I think about our user base on the healthcare side, particularly on the provider side, across two kind of distinct domains. So first of all, driving precision medicine and precision medicine research, which relies very heavily upon having the most accurate, highly curated information about the 360-degree view of a patient. So when we take the EMR of patients and we process them, we can tag them, for instance, to clinical ontologies such as the human phenotype ontology, which is very important for rare disease diagnosis, We can identify from the medical record and normalize pieces, for instance, such as their family history, which obviously informs very much upon their risk of developing certain diseases. We use our NLP a lot within the cancer space. We have cancer centers and other organizations who are particularly focused in taking all the data that exists within the cancer setting and structuring it and normalizing it for decision support, and also for clinical registry population. Cancer is one area where pretty much any decision made for a patient, whether it's to go into a clinical trial or to take kind of known gold standard treatment, relies on information that is only unstructured. So TNM, their biomarkers, their histopathology. Very rarely do we see those information in structured format. And then other areas such as kind of responses to treatment, looking at maybe a relationship between certain treatments and adverse events, etc. All of this information, our kind of toolkit is very well suited to extracting when we take that blend of approach of machine learning and ontologies to kind of get the most accurate results. The exact same approach to clinical data, in fact, can be used at the other end of the spectrum, which is in population health. So gaining very granular insights about each individual patient, when we think about individual patient-led decisions, we can use the exact same technology at a population level to have a much better understanding of the population prevalence of certain diseases, particularly diseases where organizations feel clinical coding is poorly capturing the true disease burden. This can support initiatives around readmission risk and identifying which patients are most at risk at readmitting based on the features within their population. Particularly, many of our clients take the output of NLP to augment existing predictive modeling. So they use natural language processing within feature engineering. These patient level features, when applied at population, can help us understand the groups of patients most likely to readmit within 30 days. Again, social determinants of health are really important piece of what we're doing within our clinical NLP, and something which I'll touch on later. But obviously, if we're looking at managing resource allocation and understanding drivers for missed appointments, which can be very expensive, then patients, for instance, who have documented transportation issues are much less likely to attend their clinic appointments. And knowing that up front, we can actually offer, organizations are offering things like, Uber tokens, etc., or Uber credit, so that patients are able to come into their appointments. So I wanted to maybe just take a few minutes kind of hypothetically walking through our approach to an NLP challenge, where we want to identify cohorts of patients or patients with particular characteristics that we know are poorly captured within the structured data. So I'm going to just take an example of, you want to understand the prevalence of different social determinants of health in patients with a history of stroke. And you want to drive this project. You'll use some structured data because you think you have some structured data to define your denominator, your stroke population, but you really want to drive this with insights from the unstructured medical record, because research shows that lots of the data is trapped within these records. So first of all, we would want to kind of define and build our model. And we typically would start within our toolkit. We have kind of a large library of these clinical ontologies and also of pre-built clinical models that we can kind of use off the shelf to let us do this work and let our customers do this. And I guess I haven't touched so much on the core platform, but important to say that our technology typically, in fact, with all of our provider clients, sits behind their firewall on their infrastructure. So we kind of provide the software, we can provide services, but it all sits kind of your side of the firewall. So in this approach, I'm going to first of all start by exploring some of the clinical ontologies that we have. So I'm going to use SNOMED. I know it's got good synonym coverage for things like stroke. So we would navigate through the SNOMED ontology within the platform. We can take advantage of this hierarchical nature of SNOMED and of all of these different clinical ontologies, so that when we look for, say, a parent node like stroke or cerebrovascular accident, we're going to capture all the synonyms and terms that exist beneath that in the clinical ontology. which is very powerful, and especially when we say that we can include customers' own ontologies or custom ontologies into this workflow. So we'll use that to do our kind of data exploration. Having done that, I want to also add on to that I'm really interested in the social determinants of health that these patients have. Now, I'll cover this in more detail in one of our case studies, but one of our off-the-shelf pre-built models is a social determinants of health bundle. It's the most comprehensive kind of AI package or NLP package for finding SDOH that we're aware of. We've built it over a number of years with our customers who've been looking to extract this information from medical records. So I'm going to choose this alongside, and particularly interested, say, for instance, maybe in the substance abuse category, and maybe particularly interested within tobacco abuse. I mean, for instance, I really want to see that correlation. Now, we know there's a strong correlation. I'm going to look across all of these, but this is what I've got off the shelf. So with the QVNLP platform, I don't have to really do any pre-work. The pipeline is configured. I'm going to search all of my medical records for these pieces of information. That can be done super quickly. So Les is going to show you that in the demo. We then can take the output of that data. If we think about this as our kind of our pre-screening, this is kind of going to process, you know, hundreds of thousands, millions of records, bring back lots of NLP annotated data. And then we can put a human in the loop. And this is really important because increasingly, as we kind of see the move to using more machine learning, large language model type approaches, the ability to kind of have a human expert in the loop to curate and manage results to increase the precision and recall is really important. So we're going to put a human in the loop who's going to review the output of the data within the human assisted review tool. This is one of our platforms. And as they do that, there are a number of things which they can do. They'll review the data. Now, it might be that just with the models off the shelf, that the results are of high enough precision and recall that they fit the business need that the organization had. And actually, many use cases, many of our clients will stop at this stage because using that kind of ontologies and rules approach within our NLP engine, they'll get high enough accuracy results. So that might be you have your data, you can push it down and you can act on it. You may want to increase the precision and recall of that data. And then what you can do, instead of kind of this being your final data set, the human reviewer then goes through all of these records and kind of accepts and rejects NLP hits and does some more annotation of the data within this HEART human in the loop annotation platform, which enables them to thereafter kind of train either the transformer models that are being used, or to train new models for new kind of disease progression algorithms. So if we kind of set that out in a methodology, and I appreciate we're going quite deep here. So for some of you, hopefully this is not completely going far too deep, but just to give you an idea of the kind of NLP, I guess, can be something that you can iteratively get value from very quickly in a platform like ours. You can scratch the surface and find patients and find insights very quickly, but you can also kind of scratch deeper and kind of augment those results with kind of more advanced methodologies, as I'm kind of showing here, to get really high precision and recall results, combining kind of best of different approaches. So this is kind of talking through what I've just spoken to, where we have, we've used the kind of NLP engine with its rules and ontologies to define our subset of patients. We've then used a human expert within an AI augmented tool to make the most of their time, but to curate that data. And then we can use the output from this gold standard, which is over here, to train, for instance, an off-the-shelf BERT model. And these models can come from open source places like Hugging Face, etc. But we're combining what's in the open source with what's available through our system, with the kind of proprietary technology that we have to get the highest accuracy results, and then applying that model to our larger data set, and kind of getting the output or the outcome that we want with the desired precision and recall. So yeah, a lot to take in, but hopefully for those of us who are interested in learning more about NLP, kind of scratching some of that curiosity. kind of on this, I'm really focusing a lot on, breeds and blend of best of breeds technologies. We're often asked, we're not the only organization or large organization involved in clinical NLP. And we've just released a white paper. I think the link is actually, we'll share the link to the white paper. I believe it's actually in the resources section of this webinar, looking at navigating the land of large language models and natural language processing in healthcare. And we did some off-the-shelf benchmarking for kind of extracting the types of information that are really relevant for medical records. So for instance, this is showing diseases and symptoms, and our off-the-shelf models, outperform other kind of commercially available solutions. But from our perspective, it really isn't about A is better than B. We're always looking for where, A and B is greater than the sum of the parts. And, in the previous example where I'm showing you that workflow of kind of our modeling, honing down on a gold standard of data, then pre-training, for instance, a BERT model, that's much more a best of breeds approach. And really for anyone doing NLP, whether it's with our toolkit or whether it's with anything else, that's definitely what we're seeing as having the most impact and the most accuracy in the healthcare space. It's blending techniques rather than one technique over the other. And certainly for this type of information, I can say with real confidence that kind of off the shelf, newer general purpose large language models are on their own not sufficient for information extraction from medical records. But there are ways to combine their power with kind of different approaches to actually get really accurate results. And I think if you do any reading of the literature in this space, you'll see the same. That's, it's a relatively nascent space. Obviously, there's loads of excitement, but that is the trend that we're seeing across the published literature as well. So I'm going to move into some case studies before the demo. There are a number of different case studies that I could present. I'm not going to go through all of these. The kind of main point to get across here is that we have lots of customers and lots of clients doing loads of different powerful work with our NLP platform. Each one of these represents a project that one of our clients has done. Most of these, I think actually all of these, either kind of academic medical centers or maybe integrated delivery networks, but all healthcare providers who have taken our toolkit, taken our training, and have turned it into value as an organization themselves. This is not something that we give software, then we have to configure it, we have to do services. We very much want to enable our clients. And one of the things I really like is that we have an alert, like a Google Scholar type alert and a PubMed alert for publications that mention our technology, because we don't know everything our clients are getting up to, but they're regularly publishing, and we're always coming across these great new use cases and applications of where they're having success with the tool. So it's very well proven, very well published across a broad variety of different disease areas, as you can see here: cardiology, respiratory, social, pneumonia, neurology, rheumatology, to pick a handful from the kind of 100 publications that we have. So I'm going to focus on a couple of these. First of all, social determinants of health. So I mentioned, and I showed this wheel earlier, this is the kind of the wheel of different social determinant categories that come out of the box with our platform. There are quite a lot of use cases for SDOH data emerging in healthcare. Most of the organizations that are using this just now are using it to support in kind of triaging and predictive risk modeling. So that's kind of second the bullet. But organizations signed up to the inpatient quality framework. So essentially hospitals that report inpatient quality reporting have been reporting SDOH capture voluntarily this year. It is mandated from next year, so it's going to actually have an impact on quality related payments. Social determinants of health can actually be used to prioritize the socially driven interventions, so whether or not that's kind of referral to a food bank or delivery of things like SNAP benefits. And then also within the kind of healthcare organization or provider group, but there's the ACO groups who are signed up to the ACO REACH program, which again mandates the screening and collection of social determinants of health data. NLP models help you get a real leg up on what you already have in structured data. One of our clients has shown that they had a 0.1% fill rate in their EPIC EMR for social determinants of health. So only 0.1% of patients had anything. When they processed their entire EMR against our NLP engine, they found at least one social determinant of health risk factor in 30% of their population. So like a 300 times increase versus structured data. And I think that that's going to be the case for a while. I know we are seeing better capture of structured data for social determinants, but it's going to take a long time, I think, before we see complete capture. So this is a case study from North Shore University Health System. They presented this year at HIMSS. And kind of what you see along the black arrow here is the typical type of success or value kind of statement that we get from our organizations. You know, we had a 56% increase in relevant patients screened through using this system versus previously. That in itself is an awesome result. You know, increasing the patients that you can screen because your social workers are using an AI kind of assisted approach by 56% is an awesome kind of return on investment in technology. But what's kind of much more impactful in this kind of case study is actually the patient level impact that's shown. So the workflow here is that patients present to the ED at North Shore, their medical record has been pre-processed through the NLP, and anyone who has a risk factor, social needs risk factor flagged from a prior admission is shown and triaged to the social care team, who then review in kind of like the human assisted review type workflow that you'll see from Celeste, whether or not they agree the patient has that risk factor, and if they do, they then see that patient and, you know, hopefully implement, take a history and implement something that can impact. So in this case study, a 20 to 30-year-old female presented to the ED with headache, nausea, and dizziness. It was flagged that she was previously a victim of crime and abuse. She had kind of confided that in her medical record at a previous appointment. This hadn't been acted on. It wasn't the reason that she'd come in. The information was presented to the human in the loop, to the experts for the social care team here. They then validated it, so it was correct, took a trauma-based approach from the patient and got a full history. And as a result, we're able to refer that patient for PTSD, so post-traumatic stress disorder counselling and legal assistance. So this is an example of a patient who has been referred for social intervention, who would not have been identified and would not have been triaged otherwise. So this type of real patient impact of the application of AI is really why many of us, I think, work in this space, and I think also a big kind of pillar of why organizations like AI Med exist, to kind of bring artificial intelligence to this kind of intersection of healthcare delivery. So moving on to another case study, and this actually is from Kaiser Permanente. This was published earlier this year. This is around treatment outcomes in patients with atrial fibrillation. So within the kind of cardiology department at Kaiser, they were trying to better understand the effectiveness of different atrial fibrillation treatments, but they were finding it challenging to do this because so few patients who had AF had coded recurrent atrial fibrillation, which would be the main thing that they were looking for as an indication of poor treatment response. They suspected lots more patients had this than were coded, and so they processed these patients' medical records with our NLP. Again, this is a great example. This came up, we kind of learned of this use case when it was published in March. We just know that team have been very active and trained on the software and can do this type of work. Through doing this with the NLP, they identified 3 times as many patients in certain treatment groups who had recurrent atrial fibrillation versus what they saw in the structured data. and that they actually, the tagging of patients with this and the automated pipeline with the NLP was very accurate, between 87 and 99%. So the number of cases that they had to review manually to validate was actually very low versus the overall population. So they were seeing a significant uplift in kind of number of patients identified versus the structured data. The graph kind of shows this across the two sites that they did it with. So how tall the bar is the kind of percentage increase or the percentage uplift they got with NLP over the structured data in the different treatment groups. So whether they were treated with pacemaker, cardioversion, antiarrhythmic meds, or ablation. And you can see that for most areas here, apart from site 2 pacemaker population, they're getting kind of an over 100%, over 150% uplift versus the coded data alone. So, really kind of strong performance for them. I'm going to just flip gears and kind of look more at the other end of kind of population health, but when we're talking about treatment decision making at a patient level based on their unstructured data within that kind of precision medicine space. This is from again, it's actually from Permanente Medical, which is separate to KP, but kind of the physician group affiliated with Kaiser. So every month at this organization, there's an activity that goes on to kind of take all of the pathology reports for cervical biopsies and to put them into a structured format to support decision making, because they basically exist in a completely kind of heterogeneous form, as many pathology reports do. So the NLP has been kind of configured and developed in this use case to kind of try and take what's a very manually intensive process and reduce it into something which is near completely automated. And they have done this. So they take the pathology reports, they process them through the NLP. They've taken a process which was 30 hours and kind of reduced it down to a half hour, between a half hour and an hour process. So huge increases in efficiency. And again, NLP algorithms, very accurate in classifying these reports based on the severity of findings within them. So as I say, so much data about cancer decision making relies on interpretation of unstructured data, and by doing this, and by converting this data into kind of a structured database, it's much more easily usable by the organization than filtering through multiple disparate pathology reports. So I think just about in the nick of time, I'm going to flip over to Celeste to go into a demonstration. And while she's doing that, if you have any questions you want to raise, please post them in the chat or in the Q&A, and looking forward to getting to them at the end.
I was also, thanks, Callum, going to remind people you can go into the polls and still answer the questions. Do you want to go over the results, Callum? I have kind of preliminary results now.
Sure.
Do you want to talk about them?
Go for it. Yeah, I have no idea. What do they show?
So not quite surprising on the, how are you using NLP? Are you using about 10% are using a vendor, about 40% open source. So I think kind of going back to your slide on our precision and recall on diseases and symptoms across all the different areas should be pretty, I guess, eye-opening for the people that are using open source. That is a lot of times a problem with open source, but all of those things are available for us to look at and use. And then about 50% interested in learning. So we've got a lot of people that are newer to NLP. So hopefully this presentation is definitely opening your eyes to the possibilities. And then we didn't go through the other questions, but I think some people answered them. On the SDOH and health equity, Callum spent quite a bit of time going over that. And about 75% of the people on this call actually have that as a priority. So Callum, you'll be excited to hear that, right?
Yeah, totally.
So a strategic priority for these people. So I think any way that you're starting to look at it is going to be beneficial. And if you can have an NLP solution that starts to mine that data and is correct in generating the information needed, is going to be super helpful. And then generative AI, I was actually kind of surprised. About 35% think it's a game changer. So I think that's a really, really good starting point for people to kind of start to look. And then I think about 40% think it needs a thorough investigation. So I'm not too surprised at that.
Yeah, that's super interesting.
Yeah.
I think certainly the lots of people using open source is definitely something that we obviously see. I mean, I think most, if not all, of our clients started off on open source.
Yep.
And the big hesitation from moving from open source, to try and like consolidating on something like the kind of platform you're going to show is like what happens to all of that intellectual capital and time that you've invested in your open source pipelines. The good thing is that it's all consumable within our platform. So yeah, you don't lose, any of that intelligence or any of that work that you've done previously, but you do gain the scalability, the robustness, the kind of, quarterly released software that we have, our services team, the expertise, everything else that comes with kind of a vendor solution on top of that kind of open source, one of the open source components that you can use. Cool.
You are right. I was having trouble sharing. You probably saw that. Let me try one more time here. Now that should work. Are you seeing my screen? Not yet. I lie. Now.
Got it. Yeah.
Perfect. So this will go quick. We don't have a whole lot of time. I did want to take a second to show you our platform. Callum spent a lot of time talking about the options. And for you guys that are new to NLP, I was not too long ago. I'm a pharmacist, so definitely not a data scientist. I'm not, an NLP expert, and I landed in a software company that we did NLP. And so here I am. So I kind of appreciate sometimes that this can be overwhelming. But the way that I think about NLP is just assisting my manual review. So as a clinician, I don't want to be spending all day reading charts. I want something to kind of point me into the direction that I should be focused in on. And that's what NLP does. And then you add machine learning and AI and all the other things Callum talked about, and you get just an extra additive bonus for all those synonyms and all the knowledge. So you're not only able to find things easier, but you're able to find more things as well. So what you're seeing on the screen is the human assisted review tool. This is our workflow tool for users to go in and create those gold standards or create spreadsheets or create databases of correct annotations. So our thought for this is you're asking a question of the data. And in this case, these are electronic medical records, de-identified, that we have. And we asked, in this one I'm focused in, and you can focus in right here on topic class substance abuse. So I've asked the system to find me anything that would be relevant for substance abuse. So right here, you can see I'm going document by document. You can output this any way that you want to. I could look at all substance abuse at one time if I wanted to, or I could go through any of the others if I needed to. So in this case, I'm looking at document 1987, and it's saying that there is an annotation for substance abuse. I like all the things Callum talked about. We didn't go into it in depth, but when you're looking at an NLP vendor, you want to make sure that they're taking into account family history and negation, whether they don't smoke, whether they do smoke, whether they smoked in the past. So you can see right here, this says past tobacco abuse. I'm identifying it as true, and the annotation is the patient quit smoking in 1991. This is document 1987. I'm on document 1989, but if I wanted to, I could go directly to the document, directly to this part in there, and see if there's any more information around that. The other thing I can do on this is I can say this little check mark, yes, I agree with it. And then you'll see it closes it and it moves on. Or I could say, I don't agree with that, and I can reject it. And then that's how you can create those gold standards. You can create the database output of these. Another one on here is the patient has been a smoker since the age of 10. So we identify that as tobacco abuse and true. Or in this case, substance abuse, alcohol abuse, he does not abuse alcohol is false. So a lot of NLP technology will output positive results. I think it's just as important to output negative results too. It's not only negation, so they don't have fever or something like that, but it is also things like this. So part of the Medicare regulations coming up on health equity and social determinants of health are saying that you have to not only ask people if they have these or screen people for these, but you have to say how many people have them. And so you can start to create a picture of these patients. Sometimes it's not too uncommon for people to not have smoked, started smoking, or been a smoker and stopped smoking. And so you can start to see how some of these annotations can contradict each other. And so you want a full picture of the patient. So hopefully that makes sense a little bit. Trying to, let me get this ribbon off the screen here. I don't think that you can see this ribbon, but it is taking over my other screens. Let me pause for a second. There we go. Okay, another one I wanted to show you, let me stay logged into all these, is our pathology. Callan did talk about the cancer use case. And one of the other very common use cases is that I call it kind of an interoperability use case, the need to go into medical records, extract information, and codify it some way so that you can pass it to a registry system or just another system in general. In this case, I'm showing you our ICDO. So it's going through the medical record. It's saying, you know, I want to know the topography of the cancer, histology, behavior, is it right or left, and then actually give it a code. So you can actually look at this and know we could do a SNOMED code or an ICD-10 code, or if you needed to code medications to pass along to some system. So we have all of these kind of use cases already set up too. If I wanted to, I could pull out TNM staging. I could pull out tumor size right here. I haven't asked it to do any of that, but I could start to pull out all of that information as well. And then the other one I wanted to show you real quickly was, this is just basic aortic stenosis. And again, I'm telling the system to pull out the aortic valve area. I'm able to pull out measurements. I'm able to pull out units, and I can actually normalize those units also. So if not everything was centimeter squared, I could actually put it all together. And then one of the things in this one is I'm actually giving it a severity level. I think it's severe, mild, and moderate, if I'm not mistaken. This says critical. It seems easy. We know critical means severe, but in this case, we actually had to create synonyms to tell it. So there's all these little nuances in NLP as you start to get in here that as clinicians, we know, but a system doesn't. And so that's what we've spent the last 20 years doing and perfecting, is all of that clinical language. And I don't know, Callum, let me do a quick time check. Do you want me to show anything else in here, or do you want to get to some questions? I haven't looked at how many questions have come in since I've been talking.
We can probably do another couple of minutes, Celeste.
Okay, then I'll show one more thing. I noticed that a lot of you guys on the call are a little bit more academic in nature. So I think a lot of us geek out on kind of the inner workings. So what I was just showing you was the human assisted review tool. It's kind of an interface that a user can go in and you know, accept or reject annotations and create those benchmarking spreadsheets, or just actually say that it's correct to use in a workflow. And then we have dashboards on top of that. I didn't get into quite all of that, and I'm sorry, we kind of ran out of time, but the behind the scenes of it is this interface right here that I'm showing you. And I just wanted to show you one query that we already have built. And a query for us is just the question that we're asking of the data. And the data, we kind of also didn't go into all of that. The data can be anything. It can be your electronic medical records. We do a ton of research projects on Medline articles, PubMed articles, but anything that you have, we can take in and use as a source document. And then we use these queries to ask the questions. And I wanted to point this one out because some of you guys, if you're in research, are doing research on things that aren't in ontologies maybe, or you're trying to create stuff to go into ontologies. And we do a lot of work with that in the life science space. So drug companies, as you can imagine, are often looking for things that don't quite exist in the way that we think they should. And so what we do is we create a template. This is our template right here. And then you can go in and modify it. So in this case, I've said, I want to know diseases that would go into risk factors for coronary artery disease. And in this case, I've said diabetes, coronary artery disease, hyperlipidemia. And what these little circles mean, class, is what Callum was talking about before. So I've used that ontology hierarchy level diabetes, and I've grabbed everything underneath it that is relevant. So I'm getting all the synonyms. I'm getting DM, type 2 DM if I want it, all of those. All that information I'm getting just in this one little node. And then I've created medications for CAD-related conditions. I could create anything that I wanted. So this is where if you are trying to identify research topics or something else, you could just take this query and you can modify it however you want it to. So I did kind of want to show you just a little small piece of the inner workings. This is a super easy interface to use if you have data scientists, if you have clinicians that want to go in. And then the human assisted review tool is kind of the output of that for kind of a different user to go in and accept or reject. So hopefully that helps a little bit. And I think we will get to some questions.
Yeah, let's just go straight. Oh, I'm disappeared. Where am I?
Okay, I can.
There we go. Yeah, we can go straight to questions. I think I had a slide on summary, but I mean, really just to summarize that, this is something that I've been doing a long time, and, are real experts in the space of applying NLP to healthcare data. So we would love to learn about your projects and see how we could help fast track any of the work you're doing in clinical text. So yes, Les, do you want to pull up?
Yeah, one of the questions that came in that I thought was entertaining, because it's something that clearly you are not based in the US, or you were not born in the US, whereas I am. And I think when you were putting the precision and recall up on there, the question came in, and I'm trying to find it real quick, was, are the models and that IQVIA performance figures provided applicable across both sides of the Atlantic, or are they US specific? So how are we kind of?
Yeah, so I mean, they're applicable across in different languages, different countries. I mean, the truth is the majority of our customers for healthcare are in the US, because EMRs are 15 years more mature in the US, but we have clients in Spain, in the Middle East, in the UK. We're doing work not on healthcare data, but in China. But the platform is kind of used globally for projects.
Okay. Another question on that, kind of the same thing on the gold standards and all of that. It says, are you building silver and gold standard LLM models per disease state and condition? Or is this more of a general kind of notion?
Yeah, so at the minute, we're not building and publishing specific large, as in GPT type large language models. We have the methodology for training your own, for training large language models, and that includes not just the latest generative AI type models, but also the kind of the BERT models that kind of came out in 2018. At the minute, pre-trained BERT models are more accurate for information extraction when you combine them with if you combine kind of ontologies, rules, and linguistics from the platform Celeste showed. We are kind of doing a lot more work in the use of generative AI prompting to actually configure the kind of model development stage in the platform that Celeste showed as well. But yeah, we don't currently kind of host a bunch of like disease specific LLMs. We do host a bunch of disease specific models and methodologies for training kind of transformer models in different disease areas.
Okay. And then a question I had usually comes up in the fact that, 50% of this population, when we polled, want more information about NLP. Where do they get started? You and I were both there in this at one point. How do you get started? How do you learn? And then as an organization, where do they start?
Yeah. Always good to start with something that you want to do. So with like a use case that's important to you. I mean, and then actually like in terms of like getting off the ground with NLP, you and I have done it a bunch in a bunch of different ways. There's definitely no easier way of getting results quickly than through our platform. And we've shown much of the kind of like clinical informaticist type interface, which you were showing as well, Celeste. Like the other thing is that it can all be done like in Jupyter Notebook. We have like Python SDKs, so you can do it in kind of more kind of data science type tools. Just Celeste and I are not data scientists, so yeah, we're clinical. We like being able to see what it is we're doing in the way that we showed. Yeah, but
that's true. I always forget to show that.
no, yeah, that's cool. I also saw a good question about human in the loop just come in when you.
Yeah, it was how long does it usually take? How many annotated charts do you need? How much data do we need? Can you do it as small or is it huge?
Yeah, so it unfortunately the answer is it depends. For a lot of the time, if you have a very specific question, like a narrow question that you need to extract from medical records, actually the fastest way to get into accurate results is using rules and ontologies alone, not doing any model training, because you can use linguistics to identify variations in language and very quickly make changes just to the underlying kind of patterns that are in the kind of rules-based approach. That can be done in hours. If you're looking at broader, more complex, net new things, and you, for instance, are training a model, then it can depend, because you do have to annotate quite a lot of documents. But because we use the NLP, we always use the kind of NLP rules to kind of do the silver standard creation. It's much quicker than doing, if you have to annotate, say, 500 examples, it's much quicker doing that with NLP pre-annotation than human overread. I mean, it can be like 200 times quicker in some examples. It depends. And
there are many other questions. We're not going to be able to get to them, so we're at time. So I'll let you go ahead and close it out. And then for those of you who have asked questions that we didn't answer, we'll more than happily get back with you. I think Freddie put in information. The slides will go out, the recording will go out. So Freddie, I'll turn it maybe back over to you and you can give all that information.
Lovely. Thank you so much, Celeste and Callum. Great presentations. Really enjoyed that. Thank you.
Thank you very much.
Just to pick up, Celeste, we will upload the webinar onto the on-demand page on the website, and at about 9 p.m. UK time today, an email will get sent out to everybody that has registered with a link straight into that on-demand page. The IQVIA tab on the website is where we're currently hosting all of the PDFs, and we can work with you guys to put the presentation the presentation up there as well, probably next week. So yeah, that's great. Thank you so much, everybody. Really appreciate it. Lovely to see everyone. And yeah, great. Thanks so much, IQVIA team.
Thank you very much. Thanks a lot. Bye.
Thank you.